And you're completely right. There's been an explosion of interest in precision medicine and subtyping type 2 diabetes in recent years. So moving away from this actual type 2 diagnosis to actually thinking about whether we can subdivide type 2 diabetes. And I guess the most widely known approach was developed in Scandinavia, which was the 5 subtypes of diabetes, probably 5 or 6 years ago now. And that really, I think, captured the imagination of clinicians and diabetes researchers worldwide. A real strength of that work is that it has been shown that the clusters or subgroups identified are broadly reproducible in lots of different populations and different countries, ethnicities, and so on. And also, it has been shown that the subgroups do differ to a degree in risk of diabetes complications. I think the limitations of the clusters are worth considering as well. And I guess the principle to me is that any approach that puts people in a subgroup actually loses information about the individuals, because you have to treat each subgroup the same. And actually, within a subgroup, there's probably lots of variation between people.
I see.
Right. So that might actually limit how useful the clusters or subgroups are in practice. I think a further limitation or something to consider is the fact that in nearly all the studies, there is some genetics, but studies using clinical features, there is, of course, the chance that clinical features change over time for that individual. For example, someone's HbA1c could change, their body weight. And actually, some studies have shown that means that they might actually change what subtype they belong to over follow-up, which is, again, potentially quite difficult if you're thinking about communicating that with the patient.
Exactly.
I think the final point probably is that the research is exciting, but I think it's not yet ready for the clinic, because ultimately a subtype only matters if it informs and improves treatment or clinical management. And really, there's not great evidence in that area yet that the subtypes can actually help. Indeed, we did one study where we reproduced the subtypes in trial data and showed they were reproducible again, but actually they weren't that helpful to optimize or improve or target specific type 2 diabetes medications, suggesting actually it might not be the best way forward for precision medicine. And what we actually found is that you could get much better prediction and clinical utility by actually, instead of using the clinical features to define subtypes, to actually use the clinical features directly to predict outcomes for individual patients.
Okay.
Absolutely. So I guess I'll start with giving an overview of that paper and that research, and then go on to the clinical utility. But yeah, excitingly, we've been working on precision medicine in the UK for many years now. And what we've developed is an approach that's not based on subtypes, but actually is based on the individual. So using the individual features of a person with type 2 diabetes to predict their direct treatment outcomes, thereby allowing identification of the best treatment for that particular individual based on their specific characteristics. So it's a fundamental difference to subtyping. So I guess in that area, we've had to develop a lot of new methodology over the last years, which really has culminated in a paper that we published at the end of February in the Lancet, which is fantastic, which is developing and validating the first model to help clinicians select the best glucose-lowering treatment for their individual patients using only routine clinical features. So not including expensive genetics or anything, just routine lab tests that were measured in part of diabetes care in most countries worldwide. Yeah, very good.
No, go ahead.
So that's the model. What we've done today is show that it actually works well in all the validation data sets we've tested, including in randomized clinical trial data, where, of course, you've got participants randomized to particular treatments. So you've got gold standard evidence there, from retrospective data anyway, that actually the model is useful. And what we found, I guess there's some quite interesting findings for clinicians. Actually, we see around a 5 millimole per mole average benefit from taking the best treatment as predicted by the model. So, that's not far off the glucose lowering effect of adding a whole other drug like a DPP-4 inhibitor. And it's for free because it's routine features. So there's potentially a big benefit, and it may actually be even bigger than that in certain patients, dependent on their characteristics. And I think the second point is that at least in the UK, most people aren't being treated with their best glucose lowering therapy. So actually less than 1 in 5 people in the UK have actually been started on their best glucose lowering drug. And so really it should be possible to target that remaining 80% and actually improve their glucose response and optimize treatment using the model. I guess finally, what we also showed is the model could lead to an improvement in the time before a person needs an additional drug. So it actually might reduce the treatment burden and associated costs. And it could also lower the risk of microvascular disease. So overall, we hope it's a completely new way of thinking about prescribing in type 2 diabetes. So I would encourage your viewers to check out the paper. We have a web calculator and the link is in the paper. So if you would like to try that out, you can input the characteristics and get the predicted HbA1c responses and best drugs for individuals out. And we'd of course be grateful for any feedback. So we hope one day this is going to develop into a decision support tool that can be available at the point of care to help people with type 2 diabetes get their best medication. Yeah, so that's some interesting points. And yeah, broadly, we hope so. I mean, that's the entire reason we're doing this research. It's to improve clinical care and outcomes for patients. I think what we would hope, right, is that we know that optimizing blood sugars will improve diabetes symptoms. And it can lower the risk of microvascular and macrovascular disease, so cardiovascular events, kidney disease, and things like eye problems. So by getting people on their best treatment earlier, we hope we can, the model will be able to lower the risk of those outcomes happening for people. I think the ideas around adherence are really interesting, but that's probably a whole another area of research in that. Actually, if you are telling someone this is the best drug for you, that may make them more likely to take it. It seems plausible, but we need to get data on that. Right?
Yeah, for sure.
In terms of avoiding adverse events, we have work alongside this, which we've got available as a preprint, actually, looking at modeling side effect risk and treatment discontinuation. And so in time, we hope to be able to extend the models to focus not just on HbA1c or blood sugar, but also on side effects and then ultimately heart attacks and kidney disease as well. So we'll develop that, that broad precision medicine approach and actually make that available to support treatment decisions in practice. We want to develop a universal approach to type 2 diabetes prescribing. Right?
Yes.
And to do that, we need to consider ultimately more than just HbA1c. We know that. And we also need to test and get the model working in other countries beyond the UK. So that's an absolute top priority for our next steps of our research.